for a day or two. Right then, so if we get straight on to primary care commissioning group. Are we recording already, Michelle, by the way?
No, if you can let Ryan know if you're ready to go live.
Yeah.
Okay, I've just started, so carry on.
Okay, thank you. Thank you, Ryan. We're in your capable hands this afternoon. We'll be okay. Right. So we've done all of our welcomes, just to recap, and welcome some new people today. Declarations of interest, if there's anything that you know of already or that comes up through the course of the afternoon, if you can please let me know and we'll deal with it as we go along. Thank you. Matters arising, I'm going to go over to Steph. Steph and I have had a bit of a conversation prior to the meeting due to lack of time, so she's going to give us a real quick update.
So we've had an ongoing action around the locally enhanced services. Annually, we review them. There's nothing significant to report to the committee. Those LES contracts, we review the specification and we review the performance indicators. So they're all reasonably robust. We're going to move into a phase where we now start working to assess whether we should be aligning them with North Yorkshire CCG colleagues. That doesn't mean to say that we will, just that we're going through that process. And over the course of the year, we'll just be working with our primary care colleagues just to continue to assess whether the LES contracts are fit for purpose as we move into a different way of working in provider collaboratives. So all those things that we said that we do in terms of reviewing the contracts, they're by and large completed. And we're just considering now the work around 21-22 contracts and income, which will be coming out to LMCs to discuss, and we have those meetings weekly. So yeah, I don't think there's much more to report. Julie, thank you.
That's lovely. Thank you, Steph. I really appreciate that, and your emails that were really, really helpful. The rest of it is ongoing, but I think the thing to know and for me to say thank you to is to Nigel Wells and the comms team for the letter that they sent out to our staff, all of our staff and volunteers that are involved in the vaccination and immunisation programmes. And they were really well met, and again a huge thank you from us as a committee. So moving on actually now to the body of the meeting, and it's over to Abby, and it's a theme of our committees, isn't it? It's review of effectiveness. I can see you, Abby, but I don't know whether you're frozen. Michelle, is it possible to text Abby to see if she's having
text her, yeah.
Thank you. Lovely.
She looks pretty frozen.
She does look frozen, doesn't she? I'm just mindful that if she's logging on and she's got limited time, looks like she's logged out and she's trying again. We'll give her a minute or two.
Yeah, it's just kicked her off, she said, so she'll be trying to log back on.
Okay. Suppose, Tim, I can ask you a question while we're idling. Just from your perspective, you know, what's the feedback, what's happening, especially around the vaccination, immunisation. I know you were rightfully proud last time when we were talking about it of your colleagues. And
no, I think it's shown what we can achieve if we all work together.
Really pleased the vaccine program was allowed to be done in what I probably call old-fashioned ways of getting the people on the ground to deliver it. Obviously, the really strong support from the council in getting everything set up on the Askham bar site and all the work there is what's made it possible. And I think we're an exemplar. It's no coincidence that the news guys keep popping down to York to have a look round, because it's really how it should be run. And hopefully it's a model for any future collaboration. I say so really pleased with that. I think without going too much into the stuff that we all see on the news daily about vaccine supply and vaccine production and Europe and stuff, I think we've controlled very well what we can control, and what we haven't controlled we've dealt with. So onward and upward, really. I look forward to having to generate 17,000 vaccine passports so people can go to the pub in June. I think that'll be my next job. Probably might have combined that in with giving the vaccine on reflection, might have been a useful sort of, it's all, there is a computer program, I believe, that logs both vaccines that we use every day. So maybe somebody could do some magic with that. I'm sure if Tesco's can tell me what I buy every week with my club card, the NHS computer system wouldn't be on the wit of sending everybody one of these automatically and not increasing sort of requests for letters and things. But that's probably a more personal reflection. But yeah, no, roll on. Let's get some more vaccines so we can get to the youngsters.
Thank you. Some really sound stuff, and you made us smile. Thank you, Tim, for that. And I know Phil Coatley, you had a really good experience at Askham Bar as well, didn't you?
Yeah, it was fantastic. The whole thing took about 10 minutes, the biggest part of which was parking the car and walking in. After that, staff were fantastic, really empathetic with a 59-year-old baby who hates needles, and really efficient. Didn't feel a thing. So I'm hoping I get the same nurse. I said, "Can I take you home?" And she said, "Unfortunately, I've got a job to do, but otherwise you could." So yeah, she lied convincingly as well. My perfect woman.
Oh dear, there's no answer to that one. I see we've got Abby back on the screen. Welcome back, Abby, and thank you, and apologies for the gremlins. I wish we could sort them out. But
I think it's my end, not yours, Julie.
Oh, is it? Well, over to you, Abby, then, please.
Thank you. Yeah, this is just the committee's required to review its effectiveness once a year. We're trying to do it by way of SurveyMonkey that can be sent round. With all the other committees, what we've done is asked for that to be the membership only, but I'm conscious with Primary Care Commissioning Committee that would take out most of our primary care colleagues because they're in attendance rather than the members. And I think it will be very useful to have primary care colleagues involved in that survey. The effectiveness questionnaire is in two parts. So the first is about the effectiveness of the committee, and then the second is a COVID-19 specific one. And I've tried to focus quite heavily on the impact on workforce, particularly around workforce welfare as well. I know Tim himself talks about how difficult it was when he had a care home outbreak and the impact that had personally on Tim. And I think that's certainly not unique to Tim, and we need to be factoring that in with all our primary care colleagues. So it's how we capture that information in the effectiveness return. And then I think we need to think about what we do with that afterwards. It's all very well having it, but actually what are we going to do with it afterwards that is meaningful in any way, shape or form?
Thank you, Abby.
Papers just to approve the questions that we've got, see if there's any additional ones that need to go on, and then just give permission for it to be circulated by SurveyMonkey afterwards, and we'll discuss the results later.
That's lovely thoughts from everybody, please. Yeah, lovely. Yeah, I think we've got a total agreement there by all of the nodding heads. So thank you. Yeah, and a thumbs up.
Thank you very much.
Lovely. Thank you, Abby. Okay, Simon, I believe we're over to you now, please, for the financial report.
Thanks, Julie. So again, brief from me. The primary care position overall is an underspend. That sits within an overall break-even position for the CCG forecast to year end. Bearing in mind we're only 6 days away from that now. The biggest single area of underspending in primary care is the additional roles reimbursement scheme. There was additional funds, nearly £750,000, that were we able to recruit those very specific cohorts of staff that are prescribed nationally, we would have been able to avail ourselves of that funding, but that hasn't been possible this year for probably some fairly obvious reasons. Next year, I guess, a new cohort of staff groups will become part of that scheme and process, specifically mental health workers, and given the imperative around having good, accessible mental health provision for members of the public, that's going to be really important to see if we can recruit as many as we can. That said, I'm certainly not aware of the availability of that workforce. I should imagine it's quite a competitive market, given the overall sort of mental health emphasis that's been part of the national and local investment regime recently. But overall, everything proceeding as we've forecast through the year, no particular issues to raise.
Right, any questions for Simon, please? David, and then Tim, please.
Okay, so I don't seem to have a raise your hand mechanism here.
No, I don't have one on my bar, so it's going to be the old-fashioned way.
It's just a question about prescribing. People have been keeping away from their GPs for some time now, and it may be starting to pick up now, but we would have expected there to be a quite significant reduction in prescribing costs, wouldn't we?
No, I think a lot of work was done by primary care in the very early part of the year to make sure that people who needed regular prescriptions or new prescriptions were able to access those electronically.
But wouldn't you? I understand about repeat prescriptions and so on, but you know, the number of new patients and new prescriptions must surely have been far, far less than previously.
No, I don't think we would have expected a material change, but I'll let maybe clinical colleagues give some thoughts. I can say Andrew with his hand up.
Yeah, David, it doesn't surprise me at all, to be honest, that there hasn't been a drop in prescribing. I think even from the acute side, there probably obviously been a reduction in some face-to-face contact, but there's been no reduction really in the acute workload. And actually, it's possible that there's been potentially some overprescribing, I suppose, in the sense that the triage might favour giving a prescription where a face-to-face appointment may have made it clear that wasn't necessary. So it doesn't surprise me. I don't think Tim was shaking his head as well.
Fine. Yeah, interesting.
Tim, did you want to come in on that? You had your hand up earlier anyway.
Yeah, perhaps just coming back on that point, I think it's a fair assumption, David, and I think it probably illustrates a lesson for me of probably we need to be quite analytic and scientific in our analysis of the effects of the pandemic. Anecdotes are a very powerful and emotional tool, but we ought to rely on the evidence. And I don't know if David's got any details on this, but my understanding is the evidence doesn't suggest there's been any drop-off in primary care activity. And in some areas, there's probably been an increase in activity. It's just moved on to video, phones, and online, and away from face-to-face. And if you think about it, if someone's face-to-face, you're reliant on them being there at a certain time, arriving at a certain time, moving around a building, whereas with other forms of contact, it's a bit more flexible. So you can actually achieve more workload in that environment. And certainly, speaking for our area, we've had a lot more patients enjoying the convenience of just being able to ring in and get an answer almost straight away, which is fine, but it does put a lot of pressure on the system that's not really designed for that. And I suppose the same with prescribing. I see there's an attraction to this. Has there been over-prescribing because we've been doing things differently? So I'm fascinated to see what research comes out of that. So if that's the case, or whether, in certain situations, the online model reduces prescribing because you can sort of say, well, just get back to me, rather than a face-to-face consultation where you feel you've got to leave the room having given the patient something. So that's a common phenomenon where you almost feel that you've got to do something for that person because you've got them in front of you. So actually you end up doing something because you want to help. So the complexities in the psychology of prescribing are sort of well documented. It'll be interesting to see what impacts, seismic change of workload away from face-to-face to telephone has actually had on that. So yeah, and I think it's right to ask the questions, and I think I'd be interested to hear when the dust has settled from places like NHS England, who are able to look at the statistics and the data as to what the actual impact. I'm sure there'll be many a research paper for years to come that will capture that, and hopefully we can learn from it. So, but the original point was just a quick one for Simon, was just to confirm that the underspend is lost to this system. It just goes back to central. There's no opportunity to reinvest that. Yeah, just a shame, because it's very difficult to recruit these people in COVID anyway, but it's also quite difficult to recruit them full stop. And once you've recruited them, you've got to actually find somewhere to put them. So I think there's an ambition for pace of recruitment it's going to be really hard to achieve, even once COVID's gone. So we need to be aware of that and be realistic that the PCN contract set a very high bar of recruitment, something higher than we've ever done before. And it's going to be very challenging to meet that, but also make sure it's met usefully, and we're not just rushing to collect bodies and creating an artificial market. The mental health workers is an interesting point on that. So right up until the 11th hour, we were able to recruit those as PCNs. And then literally, as the ink was drying for some of my colleagues on contracts they'd signed to start in April, we were told they could no longer do that. And they all had to be employed by our mental health provider and would only be funded 50% from the fund. So that's obviously put a screeching halt on our mental health recruitment. We're now waiting for TUV to deliver on what is an incredibly difficult task for them. They've got 32 PCNs in their area. They've got to find 32 of these people to work jointly with 32 different organisations. And they were given, I think, probably less than a month's notice. So again, it's good news that we've got extra funding for mental health, but I'm mindful that this is going to be an incredible challenge for our area to make it meaningful and make it useful. And certainly I'm not expecting to see any significant returns on that until at the very earliest, the back end of the financial year, if not moving into next financial year. So it's marrying up the narrative that we get in the national documents with what's happening on the ground. I think that, and it changes. And I think that's what we've learned from the pandemic. Things change very quickly, but it doesn't make it very hard to plan and do anything meaningful when things are changing literally a week before you're signing contracts for people's livelihoods, and people have already given notice on jobs for these. So it's a big issue locally.
I think that's right, Tim. And I know the additional roles is a very prescriptive scheme. I won't comment on that, but it does challenge things at the best of times, let alone in COVID. I'd agree there. Mm-hmm. And the change in guidance is something that's characterised the whole approach to finance this year. As we sit here, I think NHS England and Improvement are meeting as a board to agree next year's plan for the first half of the year. So with 6 days to go, they're approving what the money's going to be for next year for the first half. We won't know what the second half of the year is going to be until probably July, August. So, that global position around money is very, very very changeable and subject to last minute. And I think that goes for everything, really.
Andrew.
Yeah, I think the mental health workers is sort of going to be this year's kind of hot potato from this point of view. And as Tim says, from the LMC side, we've already had a couple of specific cases in York where practices have tried to be proactive and try to almost act in advance of this, and they've employed mental health workers who were due to start sort of just at the beginning of April, but the contracts and things have been signed. And I did mention this at governing body, and I think Steph gave me a sort of useful answer at the time. So is there any? Because I guess the frustration is obviously that the end point is completely in the spirit of what the PCN DES contract should be, in the sense that these people are in post, able to serve the population of patients. So the frustration for practice is always going to be that actually we're arguing over technicalities and kind of quite specific timelines. Is there any flexibility at all with the CCG, or is this completely a case of hands are tied by NHS England and the funding can, literally only be given in the way we've discussed?
So I'll maybe invite Dave to comment on that from an NHSEI point of view. From the CCG's point of view, looking at the guidance, it is very, very prescriptive. It has been to this point and looks like it's set to continue in that regard. I think all PCNs would value a more flexible approach, but that doesn't. I've seen no indication that that's going to change. But maybe Dave's got a.
Yeah, it seems to have been one programme where there's been next to no flexibility, and every question we've asked regionally or nationally, it's come back straight. It's the guidance is the guidance, to the point where it's better not to ask the question, which then obviously puts the CCG in a difficult position. But no, there's been no flexibility, and when we've asked, because every CCG has underspend on this budget, because it doesn't, the recruitment is difficult to match to exactly sort of start of the year and what have you, and we asked we ask for advice on what we can use the underspend on. It's always just a straight answer. It's just on one of the existing roles. There's just very little flexibility. I don't anticipate that changing. Unfortunately,
it's a shame, but it's obviously not the CCG's fault. And I appreciate there'd be flexibility from the CCG, and almost, from the LMC side, it's for me. I'll feed back that actually the CCG would have acted in good faith here and had flexibility, and that it's much higher up, unfortunately. But it just seems really daft.
I think the other issue to reflect on is to what extent and to what effect the workforce planning supports the scheme, or vice versa. So, we're recruiting paramedics, we're recruiting mental health workers, but to the extent that they're there, they can be recruited, but quite often it means you're recruiting them from different organisations, and there's an element of inflation almost built into the scheme as relatively rare resources are moving around the system to take advantage quite reasonably of their rarity.
Phil Mitton, have you got comments here for us? See, you're looking very pensive.
Just a natural look, I think, Julie. The comment that stood out the most for me was the one that was made that actually the CCG is trying to do the right thing here, but is slightly constrained by wider decisions, and will continue to do that. And the year that we're coming out of and the year that we're going into are unlike any other in terms of not being able to create certainty for employment of staff and funding for staff. So we are in an unprecedented period. We were in a committee meeting this morning. I think it was David Booker commented on during this period and beyond, the CCG should continue to operate in a value-based way and put the interests of our patients and our clinicians and professionals who work locally ahead of other matters as often as we could. So we'll continue to be guided by that, I guess, on this and other issues. It's not straightforward, Julie.
No, it definitely isn't. And I asked you because I hoped that would be your response, because that there's obviously a thread that's run through from one committee to the other that people were privy to, and it is hard. It's hard for us sitting and listening to this, especially the mental health practitioners, that we thought this is a fabulous opportunity for PCNs, to have to have their own gift of a mental health practitioner, and now that's complicated. But it must be all the more frustrating that in the midst of everything you're doing, they've sort of been almost grabbed away with you, from you at the 11th hour. Probably not the case, Andrew.
Yeah, and I think, like I say, the mental health workers is this year's main topic, but I think Tim would agree that it's part of a major problem with the PCN does essentially, and it inevitably means that rather than each PCN being able to do what they need to do, they're inevitably scrabbling for a specific type of health professional at the exact same time. It's causing all kinds of recruitment problems in terms of inflated salaries and things. And I know it's limited. I'll obviously speak to the LMC and see if there's anything that we, any influence at all that we can have on this. But I wonder if it's such an issue that it's worth thinking about whether there is any potential to actually lobby formally, if we have any collective power.
I mean, for a long time we've been talking about the gaps that we have in recruitment anyway, and we've talked about different ways of training people, especially our nursing staff, and I sometimes think it's maybe a bit too little too late, but actually, do you know what, we start from now and we try to think really innovatively about how people can do other little bits of things to free the people that have got the other skills to do that really, really complex stuff. Many GPs, I know, not on this call, but friends of mine complain profusely about the amount of admin that they have to do, and absolutely how intolerable it is, etc., etc. So if you think about that methodology, but yeah, my thoughts are, but it is, we're in it together, and I thank you for your kindness in your terms today, and the fact that we are in it together, and we get through this together, and we find really, really productive ways of working. So thank you, David, for your initial question. I think it's provoked a lovely stream of conversation, being really valuable. I noticed that Steph put some figures in the box for us, which are really helpful. So if you want to look at that, and it is about best practice, David, which is what you've put in there. So thank you all. Right, any more questions for Simon? Right, no, thank you, Simon. Steph, I believe you've got a verbal report for us next.
Just remind me what the topic is, because I haven't got the agenda open.
I shall tell you the proper one. So it's primary care end of year report.
Right, perfect, thank you. I've got the vaccine report open.
Yes.
Like most people in the CCG, we've had an upgrade on our IT, and nothing looks like it has done in the past 5 years. And we've been on Windows 7, so we're behind the times by about 15 years. So it's been a big change for us. So PCN and primary care end of year report. This is just a quick taster, really, that we are working on a position statement that actually demonstrates the additional activity that's been happening over the year. And I think it's really important because we've been focusing on the vaccines, quite importantly, but actually there's been a huge amount of work still continuing. So we're doing a primary care dashboard, and that will go out to practices that tries to triangulate a whole range of things. One around the protected income, and then the PCN income that excuse me, went out last year. And then the other thing around the assurance around the activity that just demonstrates how much primary care have, cracked on and got on with things without making a song and dance. So, the levels of activity that have continued with cervical smears, child immunizations. I think we just need to have that consolidated so that we have a picture of what primary care have continued to do alongside vaccines. So that's just a trailer for what's coming, which will be May time. And in our normal way, I'm just going to invite Fiona just to give a quick update on highlights in the PCN across the CCG.
Thank you, Steph. Yes, as Steph said, there'll be a more formal report next time. And I think what we'll look to do is also try and bring a couple of patient stories about some of the things that our PCNs have implemented that have made a real difference to their populations, because I think that helps make it really live for people and shares what's been going on. I think we're really mindful of the pressure in primary care, but particularly on the clinical directors who are juggling an enormous workload on top of everything else to try and look at the population health needs of their localities. The additional roles we've had some good debate on already, and completely acknowledge the challenges that colleagues have mentioned. But I think it's really positive to say that at the last count, there were more than 72 whole-time equivalent new posts in primary care as a result of the additional roles funding. And that has made a really significant difference in some of our PCNs about the way they're working and how they're delivering care for some of their populations. So I think that is a really good success story. And as Andrew and others have said, there'll be different challenges in the coming financial year about how we build on that, but there's been some really good positives through those additional roles. PCNs have been working really collaboratively together and across PCNs as well to look at things like improving approaches to learning disability health checks and serious mental illness health checks. And whilst we've still got quite a lot to do, there's been a huge amount of progress on that support for those vulnerable groups over the last years, which is definitely to be celebrated. And all of the PCNs, the primary care networks, are starting to get more involved in some of the population health management programs. So we've got great examples in York of work with partners around diabetes and a population health management approach there. And in Selby and the Vale, there's similar pieces of work going on, with lots and lots of partnership working with the voluntary sector and our district and council colleagues, which is really starting to challenge the way we deliver care for different groups of people and being much more creative. So lots to build on and lots of positives. I think the big challenge is recognising just how tired everybody is now and people's resilience. So as we move into the new year and we're starting to pick up, I don't like business as usual because primary care have been delivering all of this stuff on top of everything else. But as we start to develop some of the working of the primary care networks, how we continue to support the clinical directors with time and the headspace to do that is going to be a real challenge for us, I think. But I think we're going into the new year having done some really great system leadership work with partners. Certainly the PCNs have matured a lot in their first 2 years, and I think we're in a good position to take a really active role now in the sort of health and care restructuring that's going on and making sure that we carry on building on some of those services. And look forward to sharing some more detail with you in the next meeting.
Thank you, Steph. Thank you, Fiona. Have we got any questions for either? No. Interesting comment in the chat from Sharon, and it's disappeared up the line. Hang on a minute. Yeah, if the problems are being caused by national policy, have we considered speaking to MPs, political lobbying, etc.? And Steph, thank you. You've taken that up. Phil, you've just put your camera on. Did you want to?
Just to say thanks to Sharon Stoltz for the prompt about some of that lobbying influencing. Yeah, we'll give that a bit of thought. Thank you.
Yeah, thank you. Yeah, I thought it was a really good suggestion. So, and thank you, Stephanie, for taking it up so quickly. Right, any more comments? Right, okay, moving on, Steph. This is your vaccinations update, please. Thank you.
So you'll appreciate that we write a report at a point in time to get the information out, and Sean, who is taking some annual leave, prepared this for us, so my thanks to him. So you will have read that, but let me just update you where we are. So in our usual fashion, we talk about cohorts, we wax lyrical about cohorts 1 to 9, but that essentially means anybody aged 50 and above, and we've been working through groups of patients in our language, citizens of the City of York and the Vale of York, and we've been calling them forward, and we've done really well. I think you've heard that. We're having a particular focus on citizens that haven't come forward to really understand why that is. And a big thanks to Sharon and her team who've identified some resources, some of the contact tracers who are going to help us and work with some of our practices that support some of our wards where we've identified low take up. So let's just talk about what we mean by low take up. In our catchment area, most of our citizens offered a vaccine. Anybody over 60, we're in the 92% for first doses. Really, really good, really good. As we move down the age brackets, slightly less take up, but still on the whole over 80%. But we're just going to work really hard to make sure that we understand why people aren't coming forward. So that's the focus next week. We're meeting all the national targets. We work with the national team to match our appointments to supply, and that's looking really good. And we'll continue to hear great examples of how the system has worked really well together. I think, you know, quite apart from the big numbers, the big takeaway is just the positive experience that people have had of seeing different organisations, including the voluntary sector, as well as our sort of professional groups of people, really work together to deliver fantastic results on a national programme. And I don't see that changing anytime soon, even though the workforce is very, very tired. They're just fully committed to getting to where they need to be to offer a successful rollout programme. So as I say, you know, we're working well with our council colleagues to flex our approach to make sure that we offer a service that people find easy to take up. And we just continue to improve on our vaccination targets, really working on second doses now. Our care homes are all programmed in on second doses. A big piece of work over the next 2 or 3 weeks on homeless, rough sleepers, and our asylum seeker population, as well as other groups which we need to flex our approach to. So a big thanks to everybody who's actually at the front end of this work, but probably all the unsung heroes who are doing the calls, ringing people 2-3 times, running searches on GP databases to really understand how everybody who is being called forward and is eligible for a vaccine, that they get that vaccine, because it's really impacting on both low hospital rates, lower transmission rates, and less acuity when people do become ill with the virus. And Sharon may want to come in and just talk about and remind us all that the virus is still with us. Vaccination program is 100% successful, so we still continue with our public health message, and that's particularly important as we look to see how opening up and our roadmap impacts on how the virus transmits across our city.
Sharon.
Yes, thanks, Steph. You took the words out of my mouth, Steph. You've heard me talk about this on a number of occasions now, haven't you, in various situations? Yeah, the reason I'm having to leave at 3 is because I'm joining a webinar with the business sector to talk about the opening of the city and how we do that safely. And obviously, a successful vaccination program is core to that. And we're already seeing the impacts of that, as Steph has said, with reduced hospital admissions, etc. Really pleasing that our infection rate in the over 60s is now the lowest in the region, one of the lowest in the country, and a lot of that is down to the success of the vaccination program. The challenge we've got, I think, going forward is that not everyone is going to be vaccinated yet, because obviously it's still rolling out with the younger age groups. And that means that there are still going to be hosts for the virus to spread. And that's really the biggest concern as we go through the summer and as national lockdowns lifted. So somehow we have to still be just as effective in getting across those basic infection control messages about, you know, the importance of hand washing, the importance of wearing face coverings when you can't socially distance, and try not to mix with too many people outside of your kind of bubbles, are still going to be really important. And I think that's a difficult message to get across to people. But that's something that all over the country, directors of public health are going to be doing, really trying to push those basic IPC messages, which alongside vaccination are going to be key to preventing us needing to go into another national lockdown, which obviously nobody wants that, and to protect the NHS from undue pressures through people who are unvaccinated becoming very sick. So the vaccination program will continue to be important as we roll it out, but also, as Steph is aware, we're planning for what happens in winter. Well, we'll probably be having to run a COVID vaccination program alongside flu, which is clearly going to continue to put major pressures on primary care. So support to primary care to enable that to happen is part of our planning going forward as well.
Thank you, Sharon. Any questions, comments? Bill?
Yeah, just from the work done so far, Steph and Sharon, are there any discernible patterns in the sorts of groups of people who aren't taking up the offer to have a vaccine?
So, unlike other cities that have probably bigger numbers on ethnicity, where we hear in the national media, we don't have that in the sort of numbers. What we believe, and where we need to get underneath the data, we think that this is in relation to deprivation. So we need to work on something that looks like a combination of maybe a hardship fund and also bringing the service to the client. So that's the work that we've got a meeting on Monday to really drill down on that. Now, that's not to say that we won't need to make sure that a longer conversation with somebody to allay their fears, and this is where the contact tracers from Sharon's team are really going to help. You know, they're the sort of people who might be able to, with a longer period of time with a sensitivity to needle phobia, more information about the vaccine, you know, something that a 20-minute conversation might create the environment in which somebody would be persuaded as opposed to press ganged into taking a vaccine, because it's not mandated, so we'll never get 100%. But yeah, we're really getting under the detail of that, and we have been working with community leaders where that would help, with some of the faith communities, the traveller Roma communities. So I think we've got a wide approach, and of course what I've just said is, you know, over 80% have taken up the vaccine, and that's in the high 90s for some groups. So we really do have to get under the numbers, but we're getting there.
Just quickly to add to that, Phil, I think some of it is about doing myth busting, particularly for those people who perhaps rely on social media for a source of their information. There's a lot of vaccine misinformation out there. And so one of the reasons why we want to start involving our health trainers and our contact tracers, they've got the skills to be able to have those kinds of conversations with people, to try and understand their reason for vaccine hesitancy, and to try and enable people to make a truly informed choice of whether they want the vaccine or not, rather than perhaps making a choice based on misinformation or misguided beliefs about harm that the vaccine might do. So it's very much about that health promotion approach, but then also practical things, as Steph has said, about, well, how do we take the vaccine to them if that's what we need to do, rather than asking everyone to go to a vaccination centre, for example. So those are some of the approaches that we've started using.
Yeah, thank you. Yeah, a lot of the social media pieces fuel a mistrust of authority. So whether people actually believe the specifics of what's going on there, it is just about that wider thing, isn't it? Yeah. Okay, thank you.
Andrew.
Yeah, thanks. I was just curious whether there was any plans, or whether the CCG thought it was necessary to specifically counteract any of the more recent AstraZeneca scaremongering and misinformation, and is that worth a targeted approach? Or
so I'll just we haven't seen that being quoted in quite the numbers that is referenced elsewhere in the region, Andrew. Our comms team and the national team do push out through social media that myth busting, and as Sharon's referenced, any of the Q&A live sessions also address that as well, and anything that pops up on a weekly basis that is the next thing that gathers a bit of momentum. But to date, it hasn't been something that's been reported as a reluctance for our residents taking up the vaccine.
Great, thank you.
Thank you, Steph. I think that's really reassuring, because I mean, we hear all of the buzz, and you do get anxious for those people that are already anxious about having vaccination, and then they hear something that is complete misinformation, and our duty is to protect them and to ensure that we give them the right information. And sort of going back to actually when you know, when they do come for their injection, and those people that are, for whatever reason, slightly afraid of an injection, I think that from the training that I understand the volunteers have had as well, they're able to manage and enable the people that are quite anxious to carefully get to the front of the queue and are handed very, very carefully onto a practitioner who will then ensure they feel safe and get the vaccination. And I think it's really important that we do send out a really, really positive message, because we're all scared of something. Doesn't matter how big you think you are. There's always something that frightens us. And if we can just reassure people and nurture them, then that's it. We haven't got our GPs at the minute to sit there and hold our hands up. We're not through the screen. So it's that kind of
I won't repeat everything, Julie, but I literally did not feel a thing when I had the jab. In fact, I had to wait for the small bruise to develop on my arm to convince myself I had it. A bruised ego will take longer to heal, but the jab didn't feel a thing.
Oh, and as a 16-year-old, I do remember going out on the vaccination immunisation vans and being with my medical colleague and men falling at our feet. It might have been the sports car that she always pulled alongside the back and in van that they were swooning at, but I think it was the fact that these big belly firemen were frightened, but we were very kind. We even offered them a sticker and a lollipop, because then we weren't so kind to dentists. But yeah, but it is a real fear, and I absolutely appreciate that. So, but thank you everybody for everything that you're doing, and I think we have progressed in a way that I don't think anybody thought was our gift. But it is because we've worked together as a local authority right across the patch. And our teams, our PCNs, everybody has been undaunted despite absolute exhaustion. So, yeah, so thank you all. Steph, it's back to you. Oh, sorry, Andrew.
Sorry, I'll be quiet soon. If you just indulge me slightly, it's just, I think the thing to remember, or at least for me, just to sing the praises of primary care, is it really is, coming back to what Fiona said earlier, the fact that the vaccination program's been a success, and that's great. But in some respects, it always could have been. It's the fact that business as usual has carried on as well, and the fact that practices have just got on with everything else. That I think is the bit that we shouldn't forget. That's the bit that is really impressive to me, really.
Yeah, and that's what was one of the first statements I think that Steph put in the chat box, the absolute huge amount of figures of patients that were still able to access appropriately a GP. It might have been a bit different, but they still got the service that they needed and the outcomes that they needed. So yeah, wonderful. Thank you. Steph, it's over to you, and now it's the audit report.
Yeah, this is just an update back for committee members. You'll be aware that we're on a 3-year rolling programme of internal audit, and we received really good assurance. There were a number of very small comments, and this report gives you assurance that we progressed with those actions. So it's just to update people, and as I'm sure you've come to expect, the team have just got on diligently with resolving any points of note. So it's just an update report for you.
Right, any questions for Steph?
No, just a comment, Julie. It was good to see, and it's part of a continuing pattern of audit reports, particularly from our internal auditors, where we achieve the top 2 levels of assurance in everything they're looking at the moment. So keep it going. Well done.
Yeah, and I'd echo that. Thank you for that. And Steph, it's over to you again, I'm afraid, if we've no more questions or comments. So it's going to be exhausted by the end of the day, aren't you? Would you like a sip of water in between? We should have had a Diet Coke break, shouldn't we? It's on to the risk register now, please.
So colleagues may recall that, I can't remember the exact date, but when we refreshed the Quality Patient Experience Committee and the Primary Care Commissioning Committee, the risk register split, and we determined the risk appetite was either financial or in the patient experience realm. So the net result of that was that a specific risk report didn't come to PCCC anymore. Given the year that we've had, I think we felt that maybe we just needed to bring the risk report back. So the report that you've got now is just a position statement which says there's some old risks on there that we intend to close and take off, and then we'll refresh and start bringing you the revised risk report that you are used to in both QPEC and F&P. So it's just to continue that discussion about just giving you a level of assurance that we're really honing in on some of the primary care risks.
Thank you, Steph. Comments for Steph?
Just to say, Julie, I think that's very sensible.
Yeah. Was that it?
Yeah, short and sweet for a change, I know.
Thank you, but actually I'd echo that too. Thank you, Steph. It does make absolute perfect sense. And yeah, and I think it's working well. Right, moving on, it's over to David, please, for your NHS and NHSI update.
Right, so the first two items are for a decision relating to rent reimbursement. So the first one is at Pickering Medical Practice. They currently rent a room out privately to an osteopath who is vacating the room on the 31st of March. As such, that space doesn't currently attract notional rent reimbursement. And the practice would like to start using it for general medical services rather than to rent it out again. They've cited the need for additional space to support the COVID vaccination programme in the short term, and then the need for additional space to support PCN staff in the longer term. We've estimated the additional cost is going to be around about 2,366 per annum. So we're asking the committee to support that request.
So do we have any comments? Yeah, Phil.
Great. Okay.
Fine, it's very reasonable.
Yeah. Okay.
Thank you. Okay. And the second one is from Postongate Surgery. They've asked for consideration to be given to being reimbursed for an additional 4 parking spaces. So prior to 2016, the practice appear to have been reimbursed for 40 spaces, and then due to an admin error, declared 36 spaces when their 2016 rent review was due by the district valuer. So that was the amount that was they were then reimbursed for. The practice have just completed an estates project, which sees them increase their clinical capacity. So the spaces are expected to be fully utilised. So I think it's in essence a request to request a genuine admin error by the previous practice manager. So the committee just again asked if we could support that request for the additional 4 spaces.
Comments or queries? Yeah.
Excellent, Phil. That's what we wanted. Thank you.
we were wavering on that one. Actually, no, thank you. Really well written and easy to understand reports, and I believe, looking at everybody, that the decisions were in favour of granting both. So thank you for that.
And then just a couple of things also to note. I won't go through them all, but just working through. 2.3, just to say that all practices in Vale York submitted their general practice electronic declaration on time, which wasn't the case for all CCG's practices across Humber Coast and Vale. So I thought it was worth mentioning. At 2.5, it's just to make the committee aware of the digital primary care programme, which began this year. It's a revenue funding stream that can support the development of digital solutions across primary care. The funding came out quite late in this financial year, but we collectively put a plan together, and funding was used to support ongoing development of the Yorkshire and Humber Care Record, as well as some innovative projects looking at digital inclusion and some project resource to help deliver some initiatives that are coming up, including mobilising the digitisation of Lloyd George notes and supporting online and video consultation utilisation. And Sean and now Shamima are close to that project as well. So we'll try and continue to report in the good work that's going on through that programme. And then the final one was at 2.7, and this is regarding pooled resources. So we've had some ICS funding made available to support the creation of a virtual pool or to enhance an existing pool arrangement, which will ultimately support the provision of flexible pools of engaged and employed staff across GPs. So a survey was sent out to practices and PCNs across Humber Coast and Vale to gauge interest in this initiative. And we only had one practice who responded in the Vale of York and no PCNs. Now, I think probably as an action I might take forward, maybe I'll catch up with Steph, Fiona and Gary just to try and understand if that's actually because there isn't interest or just because it didn't quite land at the right time and volume of work for practice managers. So we did see that there wasn't a high response rate across Humber Coast and Vale. It was only really North Yorkshire CCG practices that came back, and maybe it just landed somewhere else at a meeting. So my understanding, it's looking at funding to support a virtual pool of staff that will make it easier for practices to call off those staff at short notice. I think we need to have another look at that and just make sure we're not missing an opportunity. And that's just the rest of the paper was for noting.
That's lovely. Thank you, David. Can I just ask, you say staff, but is that clerical staff, nurses, GPs?
I think we've got the gift to shape it as we see fit. So I think the funding is more for the platform and we could shape it locally. I think the idea was for clinical staff, but no, absolutely. I think it could be for admin as well.
Just sort of thinking that might be a bigger need and shore up the rest of our staff to get on with the day job kind of thing. That makes sense.
No, it does. It does, yeah.
Yeah, but hopefully what you can work together and you can find out why, because to me it sounds like, and I'm sure to everybody else, it sounds like a real positive. Right, any more questions for David? David?
Sorry, I just can't resist this. In 2.5 it says including artificial intelligence in online consultations, which sounds absolutely fascinating. I need to know more. But just below that, there's a wonderful phrase which I've now added to my vocabulary, which is understanding patient digital maturity, which I think is what my grandchildren mean when they say, "Get a grip, Grandad, what are you doing?" Wonderful phrase, digital online maturity. I must remember that. But artificial intelligence in consultation.
So clinic, is it?
It's clinic, yeah. So in essence, I have to admit, I'm not sure I can explain it back very well, but it's having a much more sophisticated algorithm to review the information going into the online consultation systems. And some practices in North Links CCG are working with Clinic to develop that artificial intelligence tool, but there will be benefit in Vale of York. I know quite a number of practices have changed online consultation system are now using Clinic. So I can bring the findings from that from that pilot back to the group.
Yeah, because we may not need GPs then in the end.
You won't have any, David. So careful what you wish for. We'll all have retired within the next 5 years unless they sort the pensions out.
I'm glad you spoke then, Tim, because I was just going to say to you, I can see that grin playing on your lips. You need to tell me what you're thinking.
All I'll say is I think it's a very brave claim to say this is artificial intelligence. I've certainly not come across anything that would pass the Turing test to any degree. These are not going to be computer programs that you mistake for your doctor in the same way you don't mistake Alexa for being a friend. It's just really an algorithm that asks you quite yes and no questions. It's not anywhere near what I've seen. Is not anywhere near artificial intelligence. Thank goodness.
Andrew.
Yeah, Tim's right. It's we're about to trial it over at My Health in the next couple of weeks, so I can I'll give you an update next time, David. But it is basically a way of it's triage at the very beginning of a patient's consultation, basically, and it uses some fairly crude algorithms to essentially determine whether the problem is urgent, routine, or self-management, and I think that's about as far as the artificial intelligence stretches, but I've heard very good reports from some of the practices who've used it, so I am looking forward to giving it a go, and I don't plan to retire within the next 5 years.
You should know, Tim, the nearest I get to artificial intelligence is when my 89-year-old father-in-law doesn't adjust his hearing aids properly. They sound like R2-D2. I'm sure it will come, but it's every journey has many steps, doesn't it, David? And this is the first step on a very interesting journey.
Absolutely.
This isn't going to be the robot that takes our jobs.
But actually, do you know, it's a really, really good question, David, because I did read it and I thought, but I think somebody must have told me that it was the algorithm. But I'm really glad you brought it up, because it might not have been. And we might have had some robots out there. Absolutely joking. Knew it was an algorithm.
I know, but apart from digital maturity, we were talking earlier about new ways of working and telephone triage and so on, which, in my experience has worked really well. And I think saved GPs a lot of time. So, I mean, this kind of thing seriously has got to be part of the way that we move forward, hasn't it?
Absolutely, yeah. I think we have learned so much and probably moved on several generations despite or because of what we've been through. So that we have to find the positives, and that's one of the positives. The other huge positive is the way that we've worked together. It's been amazing. Steph.
So I do think that we'll need to take a pause on telephone triage, and we are going to do a survey, patient experience survey on how they interact and how they access primary care. I have seen more and more sort of complaints come my way about patients going through counsellors to say that they don't like telephone triage, it's not the same. And we have to have that conversation with our public about how services change. And we're doing that. But I would just make the point that in those figures that I showed you, that there is a sense that telephone triage might also increase workload as well, because you've got a telephone consultation that then might lead to a face-to-face. And I just think that we have to understand it all, so that we don't assume that it's a one size fits all, because it won't be. But we do need to work across the system to understand how we shape that conversation with our service users about how things will change and how they're part of that change. So I just wanted to make that point, really.
Yeah, and it sounds it makes good sense, doesn't it? Really, if we're getting negative reports, we need to find out and unpick that, and it might be that, and I would believe that going forward we've got a balance of what works. Tim.
Yeah, I totally accept what you're saying there, Steph, but can we make sure it's done in a kind of a balanced and realistic way? And the reason I say that is we hadn't got capacity to do the level of face-to-face consults we were doing before COVID. Waits in York were going out to 3 or 4 weeks routinely. It's not, do you want telephone or face-to-face? It's, do you want telephone within a week or so, or do you want face-to-face within 8 weeks? That's your choice. It's not a face-to-face when I want it or telephone when I want it. It just, unless we significantly increase the number of clinically sort of generalists. So I won't say doctors, it's doctors, nurse practitioners, and people who can make that first contact when someone calls in. And every innovation we do it kind of frees up GP time to tackle that backlog. So I haven't had one GP with empty appointments or extra time off because of all these additional roles. It just means that week, the wait to speak to a GP or see a GP is slightly shorter than it was the week before, if you get my meaning, because we've got a waiting list. So we've got a backlog. Nobody's ever sat around there sort of waiting for a call. It just means we can get to the calls quicker. So this is all good stuff, but we need that national conversation, don't we, about what access to healthcare means, what the provision can be. You're getting Aldi, you're not going to get Waitrose, but Aldi's pretty good most of the time. But, you know, you've just got to balance that offer. I'd say probably we're slightly above Aldi in York, probably more along the kind of Tesco's value range, probably.
So I know that that's not true, but I'm not gonna. I am not going to continue with the shopping analogy. But I completely agree with you in that when we respond to the comments that we get on behalf of our citizens, we always frame the fact that we are changing. And just because that's how it was before, we're not going to go back to that wholesale because things are different. We are changing, and I do think that also the language that we use when we talk about video consultations or digital consultations, actually the majority of what we're doing at the moment is telephone dialogue, so it's interaction, and you know, just by way of, we do have an off switch in primary care, and that's the point at which all our appointments are gone. I know people, we don't think about that in the same way as primary care, but it is not an sort of limited resource. So yesterday, one of our practices had 130 patients waiting on the phone. That is not unusual. Now, that's not because they don't have a full complement of people answering the phone. That is just the demand, and there's no way of regulating that demand so it's smoothed out. So I completely accept your point, and we need to have that conversation with system partners about the role primary care play and the fact that they're not the catch-all for everybody else. And we talk, and we have spoken in this meeting about how we will support long waiters, waiting lists, but it's always in the context of our secondary care partners. Well, actually, we do need to get better at articulating that the same thing happens in primary care. We just absorb it without a huge fanfare because we don't count it in quite the same way, and we don't report it in quite the same way. So that's my energy levels peaked at the end of a meeting, but you know, we are primary care, and that's what we're here to advocate for. So
I think that was brilliant, Steph.
Yep, I just echo that, and Tim, Waitrose all the way.
Yeah, we certainly don't want the Aldi experience, which is you're going for the clinical equivalent of a pot of coleslaw and come out with a lawnmower.
Yeah, well, we're starting a range of scuba diving equipment that we're putting in one of the side rooms just to see if it will sort of take off. You know, I'll let you know how we get on, Phil.
Just make sure you put it in the central bins, Tim, then we know where we are.
I'm sure this is going on YouTube. I hope somebody can edit it quite well.
Julie, if anybody gets this far in the meeting, they deserve these little Easter eggs, don't they?
Yes, I would agree with that, Tim, actually. but no, seriously, I think we've had a fabulous afternoon, and I thank you all for your input and your energy levels, and just the respect and the way that you work with each other. It is very, very much appreciated. I think my main things that are going to go to governing body will be the stuff around and it'd be around the vaccinations and how we're doing with that, and the innovation of getting our hard to reach people actually vaccinated and safe and healthy, working with our partners, which is really, really important. And I will carefully word something around our discussion around the mental health practitioners, but I'll word that very, very carefully. And I think that's it for today, unless anybody else would like to add something else. No, are we all happy with that? Lovely. I'll check the date of the next meeting. It's 27th of May, so it's a long time before you see me again, which will be not for some of you though. I'll see you all in 5 minutes. But yes, the next meeting is the 27th of May, hopefully back to the normal time, 1:30. Thank you everybody, because of the IT platform that we're using, we had to change the time slightly. So I really, really appreciate that. For those of you that are staying for part 2 of our meeting, if you can just hang on. If everybody else, if I can say thank you and good afternoon, enjoy the rest of the afternoon. It looks like it's sunny everywhere across the country, so we're doing okay, and I'll see you very